welcome to Dublin. Welcome to Dublin's Fair City for the ESTS conference. We are going to start off with the postgraduate course Masters Cup. I'm Kieran McManus from Belfast. Enrico Ruffini is my coordinator for this session. This session is going to pit three teams against each other. Europe is going to be pitted against Asia and the Americas. We're going to have questions put on 5 topics. The first one, as you can see on the screen there, is the TNM classification. So as each team will be asked to present 2 questions, one to each of the other teams. The panel of experts and the team captains will score the quality of the scenario, and then we'll score the quality of the discussion of the answer. The main points are from the quality of the discussion of the answer. There will be a bonus for getting the correct answer, which will be given later on. Okay, we'll go through more of the details as we go along. First thing I want to do, though, is to say, could you put your phones to silent? But you will need them to run the app. The audience will be able to play along with this, and we'll be able to answer each of the questions, and that'll be totaled up at the end of the morning. And there are 3 prizes for those with the top answers from the audience. Do we have the slides for how to use the app, please? To use the app, go to the. You should have the app loaded on your phone, and if you go to the postgraduate symposium, which is down on the left-hand side, you will see that on the right-hand side there is a topic called voting. If you click on that, that will take you to the voting area, and you'll be able to vote along with each of the questions. So I don't know, are we getting those? If we get those slides, we'll give them later on. So, to get us started, I want to bring up each of our experts. Our first expert is Frank Detterbeck, and I'd ask Frank to come up to the stage, please. Frank is the Chief of Thoracic Surgery at Yale University. He is actively involved in the Staging and Prognostic Factors Committee of the International Association for the Study of Lung Cancer, and he had a major role in the development of the recent editions of the TNM stage classification of thoracic tumors. He's the ideal expert for the topic of TNM stage classification. So you're welcome, Frank. Round of applause for Frank. No. Thomas Molnar, could you join us on the stage? Thomas is the Chief of Thoracic Surgery Service at the University of Pécs in Hungary. He developed a particular interest in the history of thoracic surgery, in thoracic trauma and war injuries. He is the author of several chapters in this field and a number of publications on the topic. He therefore looks as the perfect expert for the topic of thoracic trauma. So you're very welcome, Thomas. Next we have Giulia Veronesi, who works at the Humanitas Hospital in Milan in Italy. Now, she's very well renowned internationally for a major contribution in particular to robotic surgery. She has developed a special interest also in lung cancer screening, and she's one of the most active researchers in this field. She's an author of a number of publications on lung screening. When we thought of an expert in this topic, we had no doubt in choosing Giulia. So you're very welcome, Giulia. Our next expert is Arvind Kumar. Arvind is the chair of the Center of Chest Surgery and the director of the Institute of Robotic Surgery at Sir Ganga Ram Hospital in Delhi in India. He's a worldwide expert in robotic surgery and minimally invasive thoracic procedures. His experience also includes a large experience in mediastinal surgery and thoracic infections. He seems to be the perfect expert for the topic of thoracic infectious diseases. You're very welcome, Arvind. And our fifth and final expert is Walter Vader, who is known to most of us in the society. He's the Chief of Thoracic Surgery in Zurich, in Switzerland, internationally known for his major contribution to our discipline in almost every part of thoracic surgery. His experience ranges from lung transplant to ECMO to lung cancer and airways diseases. He made a major contribution with books, manuscripts, and chapters to airways diseases. And for this reason, we've asked him to be the expert on the topic of airway diseases. So you're very welcome, Walter. So we now have, I'd like to bring the captains of each of the teams up to the stage, please. From Europe, our first captain is Alessandro Bertani from Palermo and David Waller from London. Could you join us, please? And next from the Americas, we have Steve Cassivi from the Mayo Clinic in Rochester and Ricardo Terra from Sao Paulo in Brazil. Could you join us, please? You're very welcome. And finally, from Asia, could we have Akif Turna from Istanbul in Turkey and Masayuki Chida from Tokyo in Japan. So while we get our captains seated, I now would like each of the captains to introduce their team. So we'll start again with Europe. Could David and Alessandro introduce the European team, and could you each come up to the stage as you're introduced?
Okay, thank you very much. So ladies first, from our side, I'd like to introduce you Sara Pieropan. She's from the University of Milan group, and our second lady here is Katarina Błaszewski. She's from Berlin, Germany, and I'd like to welcome her on the podium as well. And thanks for your efforts.
We have three heavyweights. We have the Spanish bull, Julio Sesma El Toro from Alicante. We have the Irish slugger, Rory Beattie from Belfast. And the man that knows no fear, Raphael Werner from Zurich.
So thank you very much. We now have the European team. So moving on quickly, we'll ask the America's captains, Steve Cassivi and Richard Terra, to introduce their participants, please.
First, I'd like to call Eserval Rocha from São Paulo and André Mioto, also from São Paulo, Brazil.
Joining them from a little further north is Gregory Jones from New York, and Luis Tapias from Boston, and Ben Dunn, who's representing Toronto, Canada.
I see the Canadians have brought in a local from Dublin to boost the team there. So you're welcome back home again, Ben. Right, moving on to Asia. Akif Turna and Masayuki Chida, I would ask you now to introduce your Asian team, please.
As I introduce the member of the team Asia first, Inren Sheng from China. And next, Yeonjin Kang from South Korea. And Aki Kobayashi from Japan.
Pallavi Purwar from New Delhi, India. And Ismail Sarbay from Turkey, Istanbul.
So we now have our experts, our captains, and our teams. You're all very welcome to Dublin and very welcome to the Masters Cup. It's time to get on with proceedings then.
I think so. To make any other announcements? I don't think so.
And if you're already in the backstage, we're already, if you all managed to get your apps working.
So very briefly, the format will be repeated for the 5 topics. So a very brief introduction of the topic from the expert, 2 minutes, and then there will be one presenting team explaining the case scenario in 1 minute, and then formulating one question at a time to the 2 responding team. And the responding team, and then there will be a thinking time for the audience and for the responding team, 30 seconds. Then, again, it is very important that the responding team can argument the choice for the right answer and the argument for not choosing the other question. You will be scored for the discussion, and you will receive an extra bonus for the correct answer, but the very important thing for the educational value is the discussion. And then, at the very end, the expert will come to the podium here, and the expert will explain the different answers, giving very briefly the evidence and the literature for the answers, and a final take-home message in 3 minutes. And this will close one topic. And this will be repeated for the 5 topics. We have 3 topics first, coffee break, and then the 2 final topics at the end. And after that, there will be the proclamation of the different prizes. Again, there are 3 prizes for the best performers, the first, the second, and the third best performer from the audience. There will be a prize for the best performance from a trainee. So the trainees who will get the best score will be awarded. And of course, there will be the Master Cup for the winning team. Thank you.
Okay, thank you very much, Enrico. So we're going to start off with our first topic, which is TNM stage classification in thoracic malignancies, according to the 8th classification. So we're going to start with an introduction, please. Frank, could you come over and introduce the topic?
Okay, well, thank you. Stage classification is a fairly basic topic that is very important to what we do. It really gives us an ability to communicate about the extent of tumor in individual patients. And that also allows us to fit it into a structure that guides us for diagnosis, how we work them up, how we treat patients. It allows us to describe patients that were included in studies, and to know whether we can apply the data from studies to individual patients. And it helps us to identify prognosis for individual patients as well. But fundamentally, it's a nomenclature, it's a classification to describe the anatomic extent of cancer. Now, this is often confused with prognosis, so certainly the extent of cancer is a major factor in people's prognosis, but prognosis depends on all sorts of other things, comorbidities, age, socioeconomic status, what type of treatment the patients get, and sometimes our need for a prognostic classification system, I think, gets confused with the stage classification system. It's only part of what determines prognosis. And we often look to what is published in the ISLAC publications for prognosis and apply that to patients. And I think you have to be very careful, because what you get from the ISLAC publications is the overall average for a large group of patients diagnosed in 1999 to 2010, so quite a while ago. We have no idea how they were treated, and there's actually a lot of variability in that database. And so if you're applying that to individual patients today that you're treating in a very specific way, I think you have to be very careful. So those are really the main points I want to introduce. One other thing of how this was developed, the ISLAC staging committee had to decide, how do you decide where to draw the line between different stage classification systems? And the decision was it can't just be prognosis, because the prognosis of a certain size tumor, for example, in Asia is not the same as in Europe. But the difference between a 3 centimeter or 2 centimeter tumor had to be useful in Asia, useful in Europe, significant in North America, significant for squamous, for adenocarcinoma. And that consistency of that discrimination is really the thing that determined it, with a lot of internal and external validation. So just wanted to give a little background, what's behind staging and why it's important.
Thank you very much, Frank. So now on with the show. First up, we're going to be asking the Americas to pose their first question.
We have decided to organize each topic in subtopics. So each continent will been assigned a subtopic. The Americas has a subtopic of lung cancer, TNM. So please, the America. Here.
A 35-year-old never-smoking man has reported a cough for 5 months and received 2 courses of medical treatment with antibiotics for a suspected pneumonia during this period. A CT scan showed a 5-centimeter lung mass with obstructive pneumonitis of his entire left upper lobe with enlarged lymph nodes in the para-aortic station 6 station, 1.5 centimeters in size. Bronchoscopy showed an endobronchial tumor in the left main bronchus, 2 centimeters from the carina. Pathology confirmed squamous cell carcinoma. PET-CT was undertaken, revealing uptake only in the lung mass itself and in the para-aortic lymph node. Brain MRI was negative for metastases. This is a question to Team Europe. What is the correct clinical stage of this patient? And here are your options.
So you have 30 seconds, and the audience also has 30 seconds to vote the correct answer.
So,
You will be scored for
right, the timer at the bottom of the screen gives you your 30 seconds. You've got 20 seconds left. So meanwhile, Europe has to come up with their answer to their discussion. Seconds left. All got your apps running? Okay, over to Team Europe to give us their discussion of this question and their answer, please.
Okay, thank you. So the lung mass is 5 centimeters large. It should be CT2B because of the diameter. And the staging 2B is regardless to the distance from the carina. The evidence of positive PET scan on N2 the para-aortic station means that the clinical stage is N2, and because of the brain MRI negative for brain metastasis, the M is 0. So we think that the correct answer is 4, CT2B, CN2, CM0, stage 3A.
So thank you very much. So Europe have given us 4 as the answer. We'll see later on whether that's the correct answer. We will now ask, we'll ask you to go on with the scenario and present the second question, please.
Our patient underwent neoadjuvant chemotherapy with partial response and was sent to surgical resection and was submitted to a left pneumonectomy. The final pathological report showed a 3.2 centimeter by 2.9 centimeter squamous cell carcinoma with free margins. There were positive lymph nodes at station 5, station 6, station 10, and station 11. The negative lymph nodes were at station 7, station 8, and station 9. The question to Team Asia was, what is the correct pathological stage and resection status of this patient? Here are your options.
Okay, 15 seconds left for the audience to answer, 15 seconds for the team to come up with their answer and their discussion. Okay, finish the voting. Now over to Team Asia for your answer, please.
Okay, this patient had the tumor size of 2A, and he received neoadjuvant chemotherapy, so it should be YP, and he had station 5 and 6 metastasis, so it goes to N2, and we did have a surgical margin negative, so the answer would be number 1.
So Asia has gone for number 1. We'll be interested to see what the audience comes up with later on when their voting comes through. And we'll see what the expert has to say later on. What I now want the panel to do, I want the panel, starting with Frank, to give a score out of 10 for the quality and presentation of the scenario, please. So from Frank, we've got an 8, we have a 9, we have a 9 and 7. Walter gives it a, Walter is giving a 9, and then we've got an 8. David's got a 6, there's a 7, there's an 8, and
You can vote.
you vote. So we've got an 8 and an 8. So that's for the quality of the scenario. Now for the quality of the discussion from Europe. Can we start again with Frank? Oh, this is bias here. 10 and a 10. Julia is giving a 9. High scores coming through at this stage. 8, a 9, a 10, a 10, an 8, an 8. We've got a 10, and then from Steve, there's a 10. So you got all those answers there? You got them good? That's and now you've given very high answers. If you get better answers in the future, you've got no wiggle room to go any higher. So we're now going to give the scores for Team Asia for the second question. Frank has given a 7. There's an 8. Julia is giving an 8. Arvin, 8. Oh, 8's well all the way through here. 8 again. David's got a 7. There's a 9, a 9, a 7, and a 7. A little bit more conservative at the end there. So that's the first round of the scenario. That now we want to move on to thymic tumors. And we want to bring Team Asia. Could you come to the dais, please?
Can you please come to the podium to present the case?
Yes, yeah. Bring that down a little bit for you. Okay.
Thank you. So you have to present the case. 1 minute.
Right.
Okay, good.
Okay. This is a 56-year-old gentleman who is never smoked before, and he's referred to us for a typical chest pain. Chest tray was as follows. So you can see the abnormality of that. And after chest X-ray, chest CT was undertaken. So he had a mass in the mediastinum and had a bit of calcification there, and looks like invaded to the lung, possibly. And the question to Team America is as follows. And what are the essential elements for the clinical stage for this patient? One is assessment of the TNM by CT scan. 2 is preoperative histology because CT findings are equivocal. The three is the tumor markers. 4 is you should forego MRI. 5 is you should go FDG PET CT scanning.
Thank you very much. You want to just stand back? And you now have 30 seconds to get your answers in, and 30 seconds for the Americas to come out. Do you want to stay here at the dais for the second bit? Okay, 15 seconds left. So time's up. Time for Team America to give us your answer, please.
We feel the most useful test here is a CT scan for the TNM staging, partly because we feel that the preoperative histology is not essential for staging, nor are tumor markers. MRI can be useful to help delineate between a T3, T4 lesion in this particular situation, but doesn't help so much in nodal or metastatic stage. And the PET CT, again, most helpful really just for looking for metastatic disease. So all up, we think a CT scan can help give you the most information looking at the T stage, the N stage, and the M stage if performed properly.
So you're giving number 1 as your answer.
So yeah, answer number 1.
Right. Okay, now we'll move on. I'll ask you to give the second part of the scenario, please.
Okay, we performed CT-guided needle biopsy to determine the pathology because we might have a germ cell tumor, which sometimes needed, or malignant lymphoma, which can be treated by chemotherapy rather than surgery. So that was confirmed as a thymoma. He underwent thymectomy via sternotomy. The tumor involved pericardium, and lung, and had metastasis in the prevascular lymph node. So question to Team Europe is, what is the pathological staging for this patient?
So there's your options. You're starting the answers now. You've got your 30 seconds. You don't necessarily have to agree with what the Americans said in their first answer. So 15 seconds to go. Voting closes now. Over to Team Europe for your answer, please.
Thank you. So because of the invasion of pericardium and the lung, we think that the T stage is 4. And because of the involvement of prevascular lymph nodes, the N should be N1. So our answer is 3, T4, N1, M0.
Thank you very much.
Thank you.
You got the answer there. So you can take a seat. Thank you very much. And now over to our panel, please. So you're now scoring the quality of the scenario as presented by Team Asia. We have a 6, a 7, a 7. Arvin gives 8, 7 from Volta, 8, a 7, a 9, an 8. Coming up with 2 8s at the end as well. Got all your answers there? And now moving over to your score for the answer from Team Americas, please. There's a 7, a 9. Julia's come up with a 7, 7 from Arvind, 8, 8, 7 from David, 7, 7, 10, and a 9. Okay. So, righto. Did we score? Did we score Europe? Oh, answers for Europe. So score from Frank first. 5, a 7, an 8, 8. Come on, Volta, all make up your mind. 8, a 10, then from Alessandro, 9 from David, 7, 7, 7, and an 8. A little bit of tactical voting there from the Europeans.
Make sure to save.
Righto. So now we move on to the topic of malignant pleural mesothelioma. And Team Europe, do you want to join us and present the scenario, please?
Okay, thank you. So this case is about a 68-year-old man who worked as a surveyor in the construction industry in the 70s, and now he's noticing that he's not as fit as his friends in the gym because he's getting breathless sooner and faster than normal. He underwent a chest X-ray and then with the evidence of pleural effusion and then an ultrasound guided biopsy of his right pleural effusion revealing epithelioid malignant mesothelioma. He was then referred for a surgical evaluation to see if his disease was resectable. This is the CT scan showing the extent of the disease at the apex, at the mediastinum level, and at the diaphragm level. So my question to Team Asia is, what is the TNM stage from the CT scan and what are any other further investigations indicated? T3 and 1, the CT scan is enough to consider resection. PET is not useful to exclude mediastinal disease. MRI is necessary for assessing local invasion, and a laparoscopy is mandatory to exclude peritoneal involvement. T4 and 1 and 2, the tumor is very bulky, with the sum of the thicknesses at 3 levels indicating poor prognosis, so systemic chemotherapy is indicated. T4 and 2, the tumor is so advanced that no useful palliation can be achieved with surgery or radiotherapy. The patient should enter a trial to immunotherapy, and no further delay to treatment should be done by staging procedures that will not change the treatment or prognosis. As the staging system is different, no decision regarding trial entry or treatment can be made until the pathology demonstrates epithelioid and not biphasic or sarcomatoid pathology.
Okay. Sorry. Thank you very much. So time to vote and time to think. So we'll wait for Team Asia to come up with their answer. seconds to go. Not any pressure there now. Voting closes now. Okay, over to Team Asia for your answer, please.
I think the answer is number 2 because the CT scan showed the invasion to the neighboring organs, so it should be T4, and we could not clearly see the exact nodal stagings, but it seems like it also had the invasion to the more than subcarinal lymph nodes, so it should be N1 or 2, and CT scan showed the bulky tumor, so we think rather than the surgical treatment, the systemic chemotherapy will be the treatment of choice.
So you have gone for answer number 2. That is correct. Okay, so we're now going to move on to the second half of the scenario. Could you present it, please?
Yes. So the patient underwent an MRI, and then he was referred for chemotherapy. After chemotherapy, he underwent restaging with an MRI, as you can see, before and after, and also with a CT scan on the left before treatment and on the right after treatment. The question to Team America is, in view of the response of chemotherapy and a subsequent CT PET showing no peritoneal involvement, what is the new TNM stage and what treatment should the patient be offered? T3N1, after such a response to induction chemotherapy, should be offered complete resection with extended pleurectomy and decortication. T3N1, the tumor was so advanced and the extended pleurectomy decortication is likely to leave an ineffective residual upper lobe and a chronic space problem, so he should be given extrapleural pneumonectomy. T4N1, the tumor was so advanced that no useful palliation can be achieved surgically or with radiotherapy. The patient should enter a trial for immunotherapy. T4N2, current chemotherapy only adds a matter of weeks to the median survival with major toxicity, so the patient should be offered best supportive care, allowing him to enjoy his limited remaining life.
Thank you.
Thank you very much. 30 seconds now for your answer, and 30 seconds before we hear from Team Americas as to their answer. Okay, 10 seconds to go. Voting closes, and now over to Team Americas for your answer, please.
We believe the best answer is number 2. The tumor was obviously very advanced and is highly likely to require an extrapleural pneumonectomy because it would be technically very difficult to do an extended pleurectomy decortication and leave a space behind at the end of it. We don't agree with answers 3 or 4, as this patient is potentially resectable based on the imaging that we have at the moment, and so should be offered curative treatment if possible. And we think that there's probably more evidence for that than evidence for the immunotherapy in this particular situation at this point in time.
So there could be a little bit of controversy and a bit of difference across the Atlantic between the different options that are available. So now we're going to go over to our expert panel. I want you now to score the quality of the scenario as presented, please. Frank? So we've got a 5 from Frank. It goes up to 10, then from Thomas, a 10. Arvind has an 8, a 10, a 9, 10 from David. There's a 5, a 7, and an 8 and an 8. Okay, so now on to how good was the answer from Asia for the first question. So Frank, the answer to Asia's question, your score, please. Bit of thought going into this one. Frank's gone for an 8, a 9. Arvind has 9, 8, an 8, an 8 from David, 9, a 9, an 8, and an 8 from Stephen. Okay, our third scoring is the answer from the Americas, please. So your score, Frank, I've got an 8, a 9, a 10 from Julia. We've got a 9, a 7, an 8, and a 1. Now this is controversial. David has gone right down to a 1. We've got an 8, an 8, a 9, and a 10. Right. So we're going to see how that comes. Thanks very much. That'll make a difference to some of the scoring. So, no, that's all the questions for the first section. We're now going to have Frank to come over and present the correct answers as discussed by various members of the panel.
Okay, well, here we are, lung cancer TNM. So the first question here, what is the correct clinical stage for this patient with this 5 centimeter tumor? So the answer was number 4, T2B, because that's up to 5 centimeters is T2B, and it was N2 and M0. And the second question, after induction chemotherapy, what is the pathologic stage and resection status? So the correct answer here was answer 3. So the T2A was a little over 3 centimeters, still had positive N2 nodes. The R uncertain I will discuss a little bit. So the next question related to thymic tumors and what are this really has to do not so much with stage classification, but stage evaluation. How do you decide what the stage is? And the correct answer here was the CT scan. That's really what we rely on primarily for determining stage. Histology is not a stage classification. And what was the pathologic stage? So this was involving lung and pericardium, T3, involving some prevascular lymph nodes, N1. And finally, the question regarding malignant pleural mesothelioma. So this patient did undergo resection, was an extended pleurectomy decortication with actually quite good lung expansion, I might note. And so the correct answer here was T4, N1, N2. This tumor was very bulky at multiple levels, and systemic chemotherapy was given. And after the response to chemotherapy, the answer was number 1, complete resection by extended pleurectomy and decortication, macroscopic complete resection. So.
Okay, thank you very much, Frank. We'll hear your comments, your wrap-up in a minute, but it's interesting to see maybe David Waller was right with that last answer. So now we're going to hear how well did the audience go. So can we just change over to the audience voting results? Right, so for the first question, the audience went for number 4, which was the correct answer. And for the second question, the audience was split mainly between 1 and 2, but in fact 3 was the answer. Okay, the next question, audience favored number 1 in particular, and that was correct. Was the audience right again in this case? Not too bad at all. No, here we're split. We're split in this one, and the audience wasn't correct in everything. And there we go again. The audience was correct in that one. That's all those questions, is it not? Right, we move back. So, Frank, some take-home messages, please.
All right. Whoops. Okay. Okay, so just to review a few things, this is the T classification. So this first tumor was up to 5 centimeters. So T2B is greater than 4, but up to 5 centimeters. Lymph nodes involving the ipsilateral mediastinum are N2, M0. So that's pretty straightforward. And so that would end up being a stage 3B patient. Now there's classification of resection, R0, R1, R2, complete resection, microscopically incomplete, and grossly incomplete. Now if you look in the ISLAC staging manual, complete resection is also defined as it has to be negative margins And six lymph node stations should be assessed. Now, it's actually a little bit unclear in the manual whether it's 6 lymph nodes or 6 lymph node stations. That's written in a very ambiguous way. Of those lymph node stations, 3 should be N2, including a station 7 node. But there is a little asterisk, and if you read a little further in the manual, it says that if a if a lobe-specific node sampling has been done, if the nodes are negative, it can be considered an R0 resection regardless. So I think there's a little bit of controversy here. Microscopically incomplete resection, positive margin, or extracapular node extension. Doesn't actually say anything about extracapular node extension with a large packet of fat around it, which you might view as negative margin, but that's not specified, or pleural lavage cytology. And of course, grossly incomplete is pretty obvious. Interestingly, extracapsular node extension comes up here as well without further explanation. Positive unresected nodes, that's fairly obvious, pleural pericardial nodules. Now, a proposed classification, this isn't actually official, but uncertain, and that would be if there's an inadequate number of nodes or stations sampled. I think this is a little bit difficult, though, because we really haven't defined very well, are we talking about 6 nodes? Are we talking about 6 node stations? And when we're talking about number of nodes, I think it becomes difficult at times. Are you talking about pieces of nodes or complete nodes? So that's, I think, left a little bit ambiguous. There's also a definition of the highest mediastinal node removed or sampled is positive. So that is in this definition. So I think that is what the team was thinking of when they said this is uncertain. I think you could argue a little bit about whether it was a complete lymphadenectomy, but I think that's not really part of the stage classification. If I stick to the stage classification of what's written in the TNM book, I think you could actually argue with those two answers that R0 or R uncertain both could be viewed as correct. Stage classification for thymic tumors, T3 involving the lung, T2 involving the pericardium, but T3, since the lung was involved, the pericardium is already included. There's a node map. These were N1 nodes. So this was T3N1. And then finally, stage classification for mesothelioma. This was a extensive tumor to start with, and there were some evidence of some nodes involved. And I'll just finish there, I think. Okay.
Okay, thank you very much. So that